This is the third video in a 5-part series on the function and dysfunction of the disc of the temporomandibular joint. The first video can be found by doing a title search on TMJ disc derangements, how and why. It is about understanding why disc derangements happen and how to prevent them. The second video can be found under the title of the VHF and jawbone geometry. It is about understanding the concept of the vertical holding fulcrum and the mathematics of occlusal reduction from maximum intercuspation to centric relation. Part 3 is titled Centric Relation and Equilibration of an Orthotic. It is about capturing centric relation and then adjusting an orthotic using the vertical holding fulcrum and jawbone geometry. Part 4 is titled Equilibration of the Natural Dentition. It is about the steps required to alter the natural dentition's occlusal surfaces to achieve centric relation. Part 5 is titled Establishing Anterior Guidance and Adjusting Lateral Interferences. It is about the final steps required to achieve total patient comfort. In this Part 3 video, we will discuss techniques for capturing centric relation, and then equilibration techniques using all the previous information to adjust an orthotic. In the glossary of prosthodontic terms, there are unfortunately several definitions of centric relation. But if one boils it down to the essence of the concept, it is really two things. The most retruded physiologic relation of the mandible to the maxillae, to and from which the individual can make lateral movements, and the maxillomandibular relationship in which the condyles articulate with the thinnest avascular portion of their respective discs. We think it makes more sense to boil this down to one definition, which would be that centric relation is the most retruded physiologic relation of the mandible to the maxillae when the condyles are articulating with the thinnest portion of their respective discs. Another definition we must agree on is that of maximum intercuspal position, or maximum intercuspation, which is MI. It is the complete intercuspation of the opposing teeth independent of condylar position. This is the best fit position of the teeth. Again, for review, we must keep in mind the definition of the vertical holding fulcrum. It is defined as the most anterior occlusal contact between posterior teeth. That is usually the lower first premolar cusp tip in the mesial fossa of the upper first premolar. The condylar movement terminology which we use are protrusion and retrusion, which everyone is familiar with, and then surtrusion and detrusion. Surtrusion is a movement of the condyle toward the eminence. Detrusion would be a movement of the condyle away from the eminence. Lastly, we will be referring to engrams. An engram is a synaptic map in the motor cortex for skilled somatic movement patterns. This definition was provided by Dr. John Jackson in 1884 and was graciously provided to me by Dr. David Cagna, who is the director of the Advanced Prosthodontic Program at the University of Tennessee Health Science Center. Dave knows everything. There have been many techniques devised by our master teachers over the years for capturing centric relation. The 5 techniques which are commonly used today are the Lucia-jig, bimanual manipulation, use of a leaf gauge, or the use of cotton rolls, and then the myomonitor. Some practitioners use a combination of these techniques to enhance their ability to record centric relation. The myomonitor is taught by Dr. Chang at the Las Vegas Institute, and we think it records a protrusive position and is therefore irrelevant to attempts to locate centric relation. Dr. Vic Lucia suggested the use of his jig to the profession, I believe, in 1964. It is an acrylic overlay which covers the upper central incisor teeth and provides a flat platform lingually for the contact of the lower central incisor teeth. The platform is ideally parallel to the plane of occlusion. It separates the posterior teeth by contact between anterior teeth and is a deprogramming device. Bimanual manipulation was devised and taught by Dr. Pete Dawson. Success is dependent upon developing the skills to use it successfully time after time. When doing this, one assumes that you can bypass the Engram patterns of the lateral pterygoid complex of muscles through what Pete called romancing the mandible. I used it for at least 20 years quite successfully. The leaf gauge was invented by Dr. J. Hart Long of Daytona Beach, Florida, back in the 70s. Hart was a great friend of my dad's and sent us the very first version with a brass clasp and some acetate leaves. The leaf gauge was taught worldwide by Dr. Bill McHorris to his many study clubs with great success. It separates the posterior teeth with anterior tooth contact. There has been some suspicion that it can be deflective if the anterior teeth are poorly aligned, but Dr. McHorris did not have a problem with that at all. It is a deprogramming device. On the left, a leaf gauge is being used to separate the posterior teeth, and on the right, cotton rolls are being used to accomplish the same thing. Cotton rolls are technically different in that they separate the teeth through posterior tooth contact rather than anterior tooth contact. They seem to be non-deflective once they are wet, and we consider them to be a reprogramming device rather than a deprogramming device. We are assuming that it is the mechanoreceptors of the posterior teeth which provide the data or postural information to establish the Engram for maximum intercuspation. Since it is the posterior teeth which, shall we say, talk to the lateral pterygoid complex, we look at this as a new engram which does not require an adaptive response from the muscles. If the new engram sent to the superior heads of the lateral pterygoid muscles does not require an adaptive response of either protrusion or detrusion, we have achieved an engram of centric relation. Reprogramming appears to occur much more rapidly than deprogramming. Another way to understand this difference is to think in terms of LPRE, the last postural requirement engram for the occlusion. The leaf gauge does not immediately change this because it's between the anterior teeth. The cotton rolls do because they provide a new data set from the posterior teeth. The leaf gauge is a highly successful technique when used properly, emphasis when used properly, to achieve and record centric relation. So are cotton rolls, and we think they have some advantages over the use of a leaf gauge, which we'll now discuss. When using the leaf gauge, patients frequently experience some muscle pain. They usually do not have pain when using cotton rolls. We think this is because when using a leaf gauge, the superior head engram remains active. When using cotton rolls, it is erased. This is because deprogramming the superior head takes place rather slowly, whereas reprogramming it is very rapid. There is another aspect of this to consider. Standard physical therapy techniques for reestablishing homeostasis of a muscle which is in a contracted or foreshortened state is to stretch the muscle. This drawing is taken with permission from Dr. Pete Dawson's book on functional occlusion. Visualize what happens if the disc is moved somewhat protrusively between the eminence and the condyle. The disc is acting effectively as a wedge between them. A loading closure force tends to squeeze the disc retrusively, thus stretching the muscle. In terms of superior head physical therapy, the cotton rolls allow a much heavier force. They eliminate the contractual engram, which allows relaxation. The heavy force squeezes the disc retrusively. The disc retrusion stretches the muscle fibers which control it. The leaf gauge, being between the front teeth, is at a mechanical disadvantage, and so is by manual manipulation regardless of skill. Both techniques are quite successful for recording centric relation. The leaf gauge has an advantage in that one can predetermine the amount of posterior tooth separation while doing the recording. Both techniques provide diagnostic information. Loading the system with the leaf gauge tests the health of that system with the current adaptive requirements. In other words, you're testing the response of both muscles and intracapsular conditions. Loading with cotton rolls tests the health of the system in the absence of the adaptive requirements after approximately 5 minutes, so one is mostly testing the intracapsular conditions. We have a written, very specific cotton roll protocol for both the procedure and the rationale. If you would like to have it, you feel free to email me and I'll send it to you. But we will now review the protocol here. Remember that the cotton rolls are placed sideways between posterior teeth. In our 5-minute routine, the timing is not necessarily critical since we do not know what is ideal for each patient. The timing is tailored to the patient's reactions as we go along. The steps themselves are critical for several reasons. In the first minute, the cotton rolls are placed sideways bilaterally between posterior teeth at the first molar, second premolar area. The patient is asked to close down very lightly, rest there, then tap very lightly and rest again. Nothing more than that. In the second minute, the instructions are to tap some more, slightly harder, then rest, and then tap in back some more, still very lightly, and then rest, and then repeat that process throughout that minute. In the third minute, the instructions are to tap and squeeze, and then rest, and then tap in back somewhat harder, and squeeze and rest, and repeat that process. In the fourth minute, the degree of pressure is tailored to the patient's symptoms, but basically it is to tap harder and squeeze pretty hard, and then rest and repeat that protocol. Finally, the alternation between tapping, squeezing, and rest is repeated with very hard force, assuming no discomfort. Finally, the patient is asked to chew around on the cotton rolls in an effort to improve disc alignment via lateral functional movements. The rationale for all of this is as follows. Twice, one member of our study club had a patient close firmly initially on the cotton rolls, and the disc popped out anteriorly. Our assumption is that the detrusion for MI required a disc posture that was at the distal rim of the disc, therefore at extreme risk of dislocation. Some condylar retrusion probably occurred before the fibers of the superior head that were attached to the disc had time to relax or release. So the combination of component positions and the loading force resulted in dislocation. For future reference, this is known as an Elliott. Don't let it happen to you. We believe that the mechanoreceptors of posterior teeth are the data input sensors for mandibular posture instructions to the superior head of the lateral pterygoid muscle as it fires to ensure precise fittings of the teeth at closure. This may include a degree of protrusion for those fibers attached to bone, which would result in condylar protrusion, and some degree of protrusion for those fibers attached to the disc, which would result in disc protrusion, which is condylar detrusion. The combination provides adaptation to the requirements of MI in both the horizontal and sagittal planes. The disc must fill the detrusive space to provide stability to the arc of closure, because heavy loading forces can be applied during function. An arcing mechanical system requires stability of the axis for accurate, repeatable movements. An argument in support of this theory comes from the veterinarian's anatomy textbook. The book states that carnivores have in their TMJ a disc with a muscle attached to it. Obviously, carnivores do not protrude. They are a hinge joint only. So apparently the only excuse for the disc with a muscle attached to it would be to provide adaptation in the sagittal plane for occlusion throughout the animal's life. This protocol applies to patients who present with TMJs which are reasonably normal. The goal is to mount diagnostic and/or treatment casts accurately to the articulator. It is not helpful for those with swollen, inflamed joints. They require a different treatment entirely. It is my belief that equilibration of the natural dentition is the most difficult procedure in dentistry to accomplish correctly. That is why I have built these 5 videos. Application of the principles discussed in the previous video on jawbone geometry and the vertical holding fulcrum are best learned with occlusal adjustment of a maxillary full arch orthotic. That is because it is the best possible training tool. It's the best possible reversible treatment tool. One uses the lower posterior cusp tips on an almost flat maxillary surface. It's made from casts mounted in centric relation, and it is a processed biacryl splint acrylic. This way one can readily control and observe the rotation of surtrusion using the vertical holding fulcrum concept. And you obviously correct the anterior guidance angles and see to it that there is no crossover lock. If one cannot achieve patient comfort success with a maxillary orthotic, the odds of doing so with a natural dentition equilibration are very low. There is one caveat to this. If the patient's MI required severe detrusion, then the orthotic will be quite thick in front in order to have sufficient material in the back to adjust for the required surtrusion. The fossa which we have defined as the vertical holding fulcrum can also be called the disclusive fossa. They are one and the same place. That same fossa provides two different functions. It is a disclusive fossa for protrusive movements, and it is the vertical holding fulcrum for equilibration to centric relation. In Gnathology 101, the posterior teeth stop the closure, hopefully and preferably in centric relation. In that solid closed position, the anterior teeth are slightly separated. One can slide shim stock out from between them. When excursive movements are initiated, the anterior teeth then separate the posterior teeth. There has to be disclusive contact somewhere, as any excursion is initiated, from the posterior holding contacts to when the anterior teeth provide the disclusive pathways. This nano distance, as tiny as it is ideally provided by the anterior and anterolateral walls of the disclusive fossa, hence the name. The following is a demonstration on how to use the vertical holding fulcrum to adjust an orthotic. The patient has worn this for many years at night only and has remained perfectly comfortable. The occlusion on the orthotic was last adjusted a little over a year ago. It was made from flask-processed biocryl acrylic, which is reasonably hard, but over time attrition of the surface does occur. Because of this, the mandible almost always migrates into both protrusion and detrusion. So adjustment of the occlusion on the orthotic needs to correct for both types of malocclusion. One more thing. This type of work, like everything else in dentistry, requires magnification, a minimum of 3.5x, preferably more. If you don't use magnification in order to provide excellence for your patients, I suggest you either go get equipped now or find another line of work. This is the fossa which houses the lower first premolar cusp tip. In other words, by definition, it is the VHF, the vertical holding fulcrum fossa, or the disclusive fossa, depending upon which function it is providing. The yellow area is the deepest part of the fossa, and that is absolutely off limits. You never, ever deepen it. It maintains the vertical during the adjustment process. That's why it's called the vertical holding fulcrum. The blue and red areas are where you may need to adjust the perimeter wall of the fossa as we achieve centric relation. But remember, never ever deeper than the yellow part. The goal is flat with the plane of occlusion. The orange area is also adjusted to almost flat so that it is never in contact during any excursive movement. These are the maximum intercuspation indents made by the lower second molars. These are the markings made by asking the patient to simply close and tap firmly on the marking paper. So this is her maximum intercuspation occlusion after a year's wear. The marks are evenly distributed and if anything are a little lighter in the molar area than in the premolar area. Dr. Wilson then asks the patient to closing back and grind hard in tiny little circles. These are the first set of marks. What he has done is to ask the patient to simulate her nocturnal bruxism. These are the marks she made before the simulated bruxism. They represent her last postural requirement, Engram. By simulating bruxism, a much greater load is applied and the more distal marks become more apparent. Whether the engram is overwhelmed or not, I don't really know, but it at least is encroached upon. Here Bob is adjusting all of the marks except the VHF, and notice that he is keeping the acrylic quite flat. He is not digging a hole at each mark. It's keeping the entire surface relatively flat. Don't touch the floor or the bottom of the VHF. It must remain flat and not ever be deepened. It is maintaining the vertical dimension. This is the fulcrum which will allow us to find and adjust all of the interferences to surtrusion. If there is functional contact around the rim of the VHF, that too should be removed in order to extend the flat surface of the VHF. Contact on the rim can be an interference to centric relation, the same as anywhere else. The patient is again asked to close in back and grind hard in little bitty circles. So this is the second set of marks. They are adjusted in the same way, keeping the surface relatively flat and never ever touching the bottom of the VHF. The process is repeated, and then this is the third set of marks. After the sixth set of marks are adjusted, he then smooths the surface with a rubber wheel very gently, very lightly, to remove the roughness from the carbide burr adjustments. Now this is the seventh set of marks, and is the point at which he will stop. Now think about what has occurred here. The vertical has been maintained bilaterally at both vertical holding fulcrums throughout the entire process. The condyles have been rising relative to the fossa or the maxilla, either retrusively or surtrusively, and probably both. In this case, almost all surtrusively. The marks within the VHF fossa do not necessarily tell you what has been going on within the TMJs, because there may have been retrusion, but also surtrusion, which produces protrusion. The net result of the two may mean that the mark within the VHF essentially doesn't go anywhere. It stays in about the same place. As we learned from the previous video, jawbone geometry is not a simple matter. Here is a comparison between the original maximum intercuspation marks and the marks achieved in the new centric relation position after 6 adjustments of the acrylic. They look about the same, but the TMJs have gone from an at-risk configuration to a much safer configuration. Completing the tune-up for this orthotic involves adjusting the protrusive and lateral protrusive incisive pathways, but that is the subject for the 5th and last video of this series, so will not be included here.